We just gave this conference yesterday for the derm residents at UT. So we'll just kind of give you the same sort of thing. It's kind of an unknown session. So why don't you guys, got 5 cases. Looks like you got about 5 or 6 people on. So there's one for everybody. So why don't we just maybe have you guys describe this and tell me what you see and kind of what kind of approach you use. It seems so tricky. There we go. So what kind of approach you use to kind of make a diagnosis here?
Okay, I can take the first one. At low power, this looks like it's a polypoid lesion. We probably have a shade that's bisected. And then if you take the top to bottom approach, the stratum corneum looks pretty.
Let me stop you with that, because a lot of people take the top to bottom approach, and I don't like totally formulaic sort of things. I mean, if you're ever answering like an essay question or something like that, and it's dealing with, say criminal law, well, you don't want to talk about contracts. So the epidermis here this is where the action is. So I know they sometimes teach you to start at the stratum corneum and then move down. Well, you don't need to do that at every time. Sometimes it's great if it's something that you just don't know, but I'd rather you say, well, we look at this, everything's set up at this point, like it's a dome-shaped papule, it's shaved. And so I like to say, well, what's really the pathologic process going on here? Do you think it's like an inflammatory process or a neoplastic process? Where's the action here? It's not in the epidermis, so there's no need to waste any time with the epidermis. I don't care about the stratum corneum here because we know that the pathology is sitting right in the middle of this thing. So an approach is good, but don't waste time when it's not relevant. So in other words, I don't want you talking about the bone here, for example, or I don't want you talking about somebody's heart when we're dealing with a skin biopsy. So the same thing is true here. We don't need to talk about the epidermis here. If you want to talk about it, you can say basically in 1 millisecond, the epidermis is not involved at all. So we're going to focus on the dermis where there's pathology. And then we're going to ask ourselves whether it's an inflammatory or a neoplastic process. That's what I like to do, is just kind of get into that. You can ask yourself what part of the body is it from, what type of technique it is, those kind of things. And those can be helpful. But I like to focus more on that because a lot of people someone has been taught somewhere, always start at the epidermis, work down. Well, no, that's not always the best way to go. It's a waste of time in a case like this to spend any time on the epidermis, other than just to say it might be near volar skin because there's no follicles here and it's got a thick cornified layer. So that being said, tell me whether you think it's an inflammatory or a neoplastic process.
So this looks like it's a neoplastic process that involves primarily the dermis.
Good.
And then we've got like some dilated vasculature in there, but predominantly it's kind of like sheets of whatever these cells are.
Right. We're having a tough time telling exactly what kind of cells they are, but we're going to work through a little sort of algorithmic approach. So if we think it's a neoplasm, what's the most important thing about neoplastic diseases?
I guess if it's benign or malignant.
Yeah, exactly. So that's really the first question we ask once we decide whether it's neoplasm, if we think it's going to be benign or malignant. Now, we're going to use other criteria. We're going to higher magnification to tell us that for sure. Sometimes we might even have to use genetic testing to tell us that for sure, but we're going to at least start off at low power. And so if you think it's a neoplasm, you think it's more likely to be benign or malignant, and why?
It looks like it's fairly circumscribed,
very well,
and it looks symmetric.
Oh, yeah, exactly. It's got the 3 cardinal features of benignity, right?
Yes.
What's the last one?
Symmetric, circumscribed. I'm drawing a blank on the last one.
Small, relatively small.
Oh, small, yes.
Small, symmetrical, well circled, the 3 S's, if you will. So you draw a line right down the middle of this. You can fold this side over on that side. It looks pretty much the same. You can draw a line right around the periphery of it. It's even, they've shaved you got to see the base here even. So they've got some dermis beneath this. So this is the whole thing. So it's small, it's symmetrical, well, so it's almost certainly going to be benign. Now, there are exceptions to those rules, like metastases can sometimes be small, symmetrical, well circumscribed. They can kind of fool you. But the vast majority of the time we see this, we favor benign. The next thing we do is we ask ourselves what kind of differentiation it's exhibiting. So at low power, if you're really good, you might be able to, tell what kind of cells these are, but you have to kind of use certain other things to kind of get it into certain categories. So do we think it's more likely to be epithelial or non-epithelial?
Non-epithelial.
Okay, good. And why do you think non?
It looks like it's kind of like well demarcated from the epidermis. It's not something that's kind of coming from there.
That's one clue that you can use, but you can get epithelial neoplasms that don't touch the epidermis, like, metastatic squamous cell, for example. So mainly, if you look at the cells themselves, you look to see if they're recapitulating one of the normal epithelial structures that lives in the skin. So it doesn't look like the epidermis, does it?
No.
It doesn't look like squamous epithelium.
Mm-mm.
It doesn't really look like a hair follicle. There's no follicular, there's no basaloid, there's no sebaceous, there's none of those things. So it's almost kind of by, process of elimination. So you say, well, it doesn't look like any classic epithelium here. So it's probably not going to be epithelial. It's possible, but it's probably not. Epithelium tends to be more cuboidal. The cells have desmosomes, they're touching one another. Whereas non-epithelial, what do they generally tend to look like?
They're usually more dispersed and kind of spaced out. They have like this darker.
What's the most
color.
common shape of a non-epithelial dermatologic neoplastic process?
Maybe
Spindle.
like
Spindle. Good. Spindle. That's the most common. And it's not the only one. Obviously you can get non-epithelial neoplasms that come from the hematolymphoid origin. There are others, but vascular things like that. But you're right. If you think spindle, you sort of think non-epithelial. Well, these aren't spindle. They may be epithelioid. And what's the color of these, would you say?
They're kind of like light pink or kind of have this like
They're
grayish
pale.
look.
Pale, like pastel. They're pale. So we think, well, it certainly doesn't have a lot of DNA, right? The more DNA, the more purple. The less DNA, the less purple. So, this is going to be maybe more cytoplasm than nucleus when we go to higher magnification. So let's go to higher magnification, see if we can tell what kind of differentiation we're exhibiting. So we think it's non-epithelial. And here we go to higher magnification. And I think we can kind of agree that it's non-epithelial, right? These don't look like keratinocytes, they look like follicles, they don't look like neuroectoderm. What kind of cell are we looking at here?
There's a couple of giant cells in there.
Yeah, there's quite a few giant cells in here. And if we look around in other areas, here's one that's even got some, several different nuclei here, and it's kind of got this pale cytoplasm surrounding it. So what kind of giant cells are we looking at here?
So I think they're Teuton giant cells.
Yeah, these are Teuton giant cells. When you get a wreath of nuclei, and these aren't the world's best formed Teuton giant cells, but they are Teuton giant cells. We get kind of a wreath of nuclei surrounded by this pale cytoplasm. We'll call them two-tone giant cells, the way to remember it. That's characteristic. So when we talk, and what are these other cells here besides these multinucleated ones here? What are these other cells in the background?
I think there's like a couple of maybe some lymphs or plasma cells in there.
There's some lymphocytes. There's a few scattered lymphs in here.
Maybe histiocytes.
Mostly they're just histiocytes. They're just, so you got multinucleated histiocytes with Teuton giant cells, and then you got other histiocytes that don't have Teuton giant cell morphology. So when you get a proliferation of a process where there's a predominance of histiocytes, what do we call that?
Like a histiocytosis?
No, we call it granulomatous inflammation. Granuloma, it means that there's granulomatous. When histiocytes predominate, it means that it's inflammatory inflammation, and we talk about that being granulomatous. Now there's actually more than five, but there's five main patterns of granulomatous inflammation in the skin. I don't know if you know those.
I know naked is one of them.
No, that's not really a pattern, but what you're talking about, naked granulomas, that is a sign of a pattern that we talk about. Which one is it? What disease has naked granulomas?
GA.
No, no, but sarcoid, right? Sarcoid.
Oh yes, sarcoid.
So sarcoidal granulomatous dermatitis is one pattern. What pattern is GA?
It's
palisaded granuloma. And then we have suppurative granulomatous dermatitis. We have foreign body granulomatous dermatitis, and then we have tuberculoid granulomatous dermatitis. Those are the 5 major patterns of granulomatous inflammation of the skin. And sometimes you get this pattern where you get cells that have foamy cytoplasm, at least in some of the cells, plus more just garden variety histiocytes. What do we call that type of granulomatous inflammation? Xanthogranulomatous inflammation. Okay, so we got 2-ton giant cells, we've got histiocytes, we've got xanthogranulomatous inflammation. What's the diagnosis?
Xanthogranuloma.
Yeah, xanthogranuloma. It's exactly what this is. So this is I was talking about juvenile xanthogranuloma. I mean, this might be adult. You get plenty of these in adults too, but this is an example of a xanthogranuloma. Okay, so it's a nice characteristic example of that. Sometimes they have more 2-ton giant cells than others. If you get them early, they may have a lot of inflammation and histiocytes and eosinophils, and you don't really see any 2-ton giant cells when they're really early. But later in life, when they sit around for a little longer, they actually get more 2-ton giant cells. This is probably kind of a teenage version of it. It doesn't have as many 2-ton giant cells as they often have, but you can still make the diagnosis. Okay. Now there's an entity that's in the differential diagnosis of that. This is a better example. And notice here, you've got these cells. They're also histiocytes, and they look a little bit different. They have kind of a amphiphilic pink cytoplasm. They don't have the foamy cytoplasm. And this is an example of a reticulohistiocytic granuloma. Okay, so juvenile xanthogranuloma or just adult xanthogranuloma usually occurs as a solitary lesion. There are some forms that can be multiple and widespread. It can be associated with juvenile CML. So there is and also with neurofibromatosis, interestingly enough. So there are some cases of XG that can be associated with other diseases. This disease is associated with mutilating arthritis when it's multicentric reticulohistiocytosis. So these are in the family of the so-called non-X histiocytosis diseases, non-X histiocytoses. Okay, let's go to the next one. This ought to be so simple for you guys as general pathologists that you're going to think I'm insulting your intelligence. I don't like to call on people, so
I can take one. I guess I try to take this one, the easiest one.
Good. You always make it hard.
Yes, I understand. Let's see, this like, I don't know if the whole lesion is like this. I think it's relatively well circumscribed, maybe a little encapsulated, very thin capsule.
What kind of biopsy is this?
Excisional biopsy in this one.
Well, what's missing here?
Like the skin part is gone.
There's no epidermis.
Yeah.
That's exactly right. There's actually no dermis or anything, right? So I know guys don't see patients anymore, but you're gonna have to imagine that you're in the room, maybe you're rotating on dermatopathology, and patient comes in. What do you think they're gonna be presenting with? Is it a rash? Is it rule-out melanoma? What do you think the complaint's gonna be here?
Probably like a
I
nodular
guess color lesion, some discoloration, red, a bump.
What do you think it's going to look like? You think it's going to be, where do you think it's going to feel like? You think even if it'll see much? There's no skin. So it may not look like much of anything. It might be a little purplish or red that you might see, but maybe nothing. You may have to feel this, right?
Yeah, probably deep in the skin.
Yeah, this is probably it's subcutaneous, or it's actually
Mhm.
cutaneous. It's certainly subdermal. So it's like a dermal nodule.
Mhm.
So in order, when you get somebody who's got like a little marble in their skin, they often do like a little incision on the top of it and it pops out. It's called an enucleation biopsy.
Right.
You may not have heard of that in dermatology, but you've heard of an ocular pathology. If you want to, take out somebody's eye, you nucleate the eye, right?
Yeah.
So this is the same thing, only it's basically you're just enucleating a little tiny skin lesion. And whenever lesions pop out of the skin like that, it's a sign that they're like 99.99% of the time it's benign.
Sure.
It's like a metastasis to the skin, that doesn't pop out. It may feel the same, but you cut into it and that's not going to pop out. So this is going to be a benign lesion based on that. But what about looking at our architecture here?
I think it's being like mixed with looks like mature fat and then maybe vessel and some stromal cells.
Yeah, but it looks benign based on our symmetrical, well circumscribed, all the small size, all the things we talked about before, right? So then you're going to ask yourself, what kind of differentiation? So is this epithelial or non-epithelial?
No, it's not epithelial. It's more like a syncable.
We're looking mostly at fat. That's not epithelial, right?
Yep.
Okay. Okay. So is fat the only thing we see here?
No, there's other 50% of stuff here, either vessels and then the other fibrosis or stroma around.
Yeah. So what are we looking at? We go to higher magnification here. What are these cells here? What are these things actually doing here?
I think those are all of the vessels and the like the fibroblast cells around it.
Yeah, there's blood vessels, a lot of blood vessels. And what are these blood vessels? What's the configuration of these blood vessels here?
Like tiny capillary.
Good, they're capillaries. They almost look like they're forming kind of a lobular capillary proliferation, if you will.
Mm-hmm.
Lobular capillary proliferation, plus fat, right?
Yep.
So what's the diagnosis?
I want to attempt to put a like angiolipoma to it.
Yeah, angiolipoma. Angiolipoma, good. It's classic for angiolipoma. And what's interesting about angiolipoma is sometimes you can get lots of angiomatous component. So in other words, if we just had a high magnification view of this, you wouldn't call it angiolipoma. You would call it, maybe some kind of a variant of an angioma. I mean, the morphology of the angiomatous component of a angiolipoma looks a little bit different than just a capillary hemangioma that we see, when we do a shave biopsy of somebody that's got a cherry hemangioma, something like that. It looks a little bit different. But still, you wouldn't just call this a lipoma of any form when you just saw this. So sometimes you just get a small amount of the vascularity. Sometimes you can get like, this one's probably, 50 to 60% of the lesion is the vascularity. It's kind of interesting. So you really kind of need the overall architecture demonstrating the lipoma component to make the diagnosis of it with certainty. Okay.
If we see a lot of smooth muscle, like component of smooth muscle in it, or can we just call it angiomyolipoma?
Yeah, I think this is just some stroma here. I don't really think.
No, not in this case. If we see like.
Oh yeah, there is.
Yeah.
Well, okay. When you see smooth muscle plus vessel and fat,
yeah.
What do you call that?
Angiomyolipoma.
Yeah, and what disease is that associated with? It's almost pathognomonic. Yeah, it's almost pathognomonic of tuberous sclerosis, especially when they occur like in the kidney. That's really the most common location in that area. They don't usually occur on the skin that much. I've seen a couple over the years. Mostly they're just internal when they're angiomyolipomas. But yeah, that's good. But this one didn't have that in there. It's just a classic angiolipoma. Now, there's a lot of other types of lipomas in the skin, right? So what are some other types of lipomas?
I'm not sure.
Okay, good answer. Who knows it? Who knows some other types of lipomas?
Like a
Spindle
hibernoma?
cell lipoma.
Hibernoma, yeah, that's an interesting one. That's actually a little different animal. That's kind of a tumor of brown fat, but yeah, it's I would accept that. But there's several other variants of lipomas, one of which I'm showing you right here.
It's more like myxoid.
Fibrolipomas.
What's that again?
Fibrolipomas.
Good, fibrolipoma. Yes, that's one. What's another one?
Spindle cell.
Spindle cell lipoma. Good.
Myxoid.
Myxoid
lipoma.
lipoma. Excellent. Yeah, those are round cell lipoma, pleomorphic lipoma. So, lipoblastoma, a childhood lymphatile lipoblastomatosis. So there's several different of those. So this is an example. Which one is this one?
Myxoid.
Yeah, this is myxoid. Myxoid and spindle cell there's kind of an overlap there. Just about any time you see spindle cell lipoma, you're going to see some myxoid elements to it. So this one's almost all myxoid. It doesn't have much fat left in it. So there's really a massive amount of mucin. It can kind of almost obscure the fat. Okay. So that's a myxoid lipoma.
This one looks like kind of tissue culture looking for a nodular fasciitis.
You really need more cellularity for nodular fasciitis, I think, and some more inflammation. This is really just more mucin here.
Okay.
So I think that would favor that.
Thanks.
Okay, now we're going to some different type of stuff here. This is more inflammatory skin disease. Okay, so who wants to give this one a go? It's pretty easy because not much to see, is there? So when we're looking at something like this, can you give a definitive answer right now about anything? Could I give a definitive answer about anything right now?
I could not.
No, you can't. So what are we testing you on here? What's the test? What are we trying to get you to be able to do when we show something like this here?
Forming of differentials.
Yes. An approach. What's your approach to dealing with something like this? What's the overall category when we're looking at a piece of skin like this? So the overall inflammatory pattern that we're showing here.
Probably some type of collagen related disorder, disease.
Well, probably we just talked. It almost looks like normal skin, right?
Mhm.
Looks like nothing. So
Like
we have
superficial.
yeah,
Maybe
probably
superficial
kind of
perivascular.
superficial perivascular or sparse perivascular dermatitis. I mean, it doesn't really look very like there's not much going on here. The last two lesions we had a lot going on. This has almost nothing. So when you have almost nothing at low magnification, you have to have an approach. What are diseases that cause almost no pathology at low magnification, but there's a pathology in the patient, when they're in the room. So you have to say, well, what could this be? Could it be something a very sparse superficial perivascular dermatitis? Could it be a pigmentary disorder? And this is one where you can look at the cornified layer. There are diseases that affect the cornified layer. They just don't give you much inflammation, but they still are pathologic in a patient. So you have to have an approach. We talk about the normal skin approach. So at low power, we don't see much of anything. So sometimes the fact that you don't see something is important. So let's go to higher magnification. Let's see if there's anything we can do to kind of refine that. So now you can look in the cornified layer. Who wants to do that?
I can do it.
Is there anything wrong with it?
Um,
No.
No.
It's normal. There's nothing wrong with it. So we can rule out things like fungus, axillary granular parakeratosis, exogenous tattoo, ichthyosis. So you can rule out a lot of stuff there. This is a rule out deal here. So it's a little harder. What about the epidermis? Normal or abnormal?
Normal.
Pretty normal. Yeah, this is within the range of normal. Now, this is probably like maybe the neck could possibly be the antecubital fossa. It's got a little bit of papillomatosis to it. So that just is normal for the skin. There's no spongiosis here. There's no acantholysis. There's no abnormal pigmentation. We see there's some melanin here, so it's not depigmented. So it's pretty much epidermis is normal. So it's a dermal process. There's no deposit here. There's no amyloid. There's no mucin. But as you look down here, there are some inflammatory cells here, aren't there? Between and among collagen bones. What kind of inflammatory cell is this?
There's some EOs in there.
There's an EO, neutrophils, perivascular, and also sparse and interstitial. So what disease do you know that causes that pattern?
If it's like a drug or a bite.
Well, bite is generally going to be a denser infiltrate. Classic bite is superficial and deep wedge shaped with pretty dense infiltrate at the top that gets less at the bottom. So this is sparser than most insect bites. If this was a bite, it'd have to be a pretty weak bite. But what disease classically gives you a very sparse infiltrate with some neutrophils, some eosinophils scattered like this? It's really sparse. Shows almost very limited inflammation. Look at it under the microscope, like here. A drug can cause this, but that's not the actual diagnosis here. So what if you eat a strawberry and then you start getting, your skin gets itchy and you start getting lesions?
Or like eczema.
What's that? Somebody said something I couldn't hear.
Like eczematous reaction.
Well, how about urticaria?
Urticaria.
Hives, right? Urticaria. That's what this is. So if you have somebody that has a hive and you biopsy it, it comes up like in, 5 minutes after they eat a strawberry. This is what it looks like. Okay. This is exactly what you see with urticaria. Very sparse infiltrate, eosinophils, often neutrophils. You get a spectrum. Some have lots of inflammation with lots of neutrophils. Some have almost limited inflammation like this. This is the most common pattern that we see. So this is urticaria. Now, the reason that we get lots of biopsies for urticaria is because everybody's worried about urticarial vasculitis. There's no vasculitis here. There's no fibrin in any blood vessel walls. There's no thrombosis of any lumen. So this is not urticarial vasculitis. So the ratio of biopsy to real urticarial vasculitis is probably a 10,000 to 1. It's almost never urticarial vasculitis. It's almost always this. But everybody's worried about it. Oh my God, I don't want my patient to have urticarial vasculitis. And they almost never do. Patients are bad historians. They say the lesions have been there for more than 24 hours. And that means usually the whole episode's been there for more than 24 hours. So here's another example of a lesion that would look urticarial, meaning it looks like urticaria clinically with no epidermal involvement, no spongiosis, no scale, no nothing. It looks like a hive, but this one's loaded with neutrophils. And they're present interstitially mostly. It's not as dense and diffuse as sweets. There's no papillodermal edema here, but you've got a lot of neutrophils. Okay, and this is what you see in the autoinflammatory diseases, like adult Still's disease, and things like that. Okay, so this is an urticarial process. It's got mostly neutrophils in this case. So that's in contrast to the last one. Okay, this is one you guys ought to get here also, or at least should hopefully get into the right category.
So for this one, it looks like the epidermis looks okay, maybe a little atrophic or flattened, but underneath we have this like dense infiltrate.
Yeah,
It
that's
looks very blue.
pretty much normal epidermis, just so you'll know. That's fine. You know, that's what we hope our epidermis looks like. But there's abnormality in the dermis, right? Absolutely. You think it's an inflammatory process or a neoplastic process?
Right now I'm thinking more inflammatory. I don't know what the blue cells are, but maybe inflammatory.
Yeah, they look like inflammatory cells. I will agree with you. So when they're bluish like this, what do you sort of think of initially?
Lymphocytes are like neutrophils.
They could be neutrophils, but neutrophils at low power, and again, I don't want to make you sort of an expert at 10,000 foot diagnosis necessarily, but they look a little bit different. They look a little kind of salt and peppery like. You get sort of, they don't have as dense of, you know, again, if you look at a lymphocyte at high magnification, it's 100%, you know, nuclears. You know, it's all DNA and all that stuff. So it's nucleic acids. Neutrophils have more cytoplasms. They don't look quite as dark. So neutrophils at low power look a little different than lymphocytes. Lymphocytes look black, basically, at low power. You say these, well, you know, these are probably some lymphocytes, but they're not all lymphocytes, most likely. I agree with you. There may be some polys or some other cells in there. Okay. And then what about the area between the epidermis and the dermis? Is that significant?
The Grin Zone.
Good. Grin zone. What does that mean? Grins. You may not know.
It's just like, I know it's like the collagen layer in between.
Is it named after Dr. Grins, or where did the name come from? It's actually the German word for frontier. It means like the border between one process and another. So we're talking about a Grin zone. It's kind of like, it goes back to World War I, you know, basically when they had no man's land. So you don't want to go in here. That's the Grin zone. It's an area that's unaffected by the pathology. And it's usually, we talk about it being between the epidermis and something going on in the dermis. And that's a clue to certain diagnoses. It's not a diagnostic feature of anything, but it sort of goes along with certain processes that like the reticular dermis and don't like the papillary dermis so much. It's just kind of a finding that we see. Okay, good. So let's go down a little higher magnification. So we've decided we think it's an inflammatory process. Do we still think it's inflammatory? If it's inflammatory, it's kind of a dense, diffuse pattern, right? We're at higher magnification, say, well, gosh, it's pretty diffuse, but it's also got these cells that look like they're almost arranged in these cords and strands. Can you recognize that? See this?
Looks like a linear pattern, makes me feel like this is carcinoma picture.
Okay, so you're talking, so you've been taught that when you see an interstitial pattern with cells and cords and strands, that should make you think of some type of metastatic process going to the skin, one of which is metastatic carcinoma. Which is the most common metastatic carcinoma?
I guess in this is ductal.
Well, just, yeah, metastatic breast cancer. Yes, that's right. That's by far the most common one to do that. Not the only one. You know, we see it in prostate sometimes, and we see it in other things. And then we see it in this disease. This entity. Is this metastatic breast cancer?
Looks like not likely.
No, it doesn't look like metastatic breast cancer. You know, you could maybe, if we had just zoomed in maybe on just a few of these things here, you might say, yeah, well, that's maybe metastatic breast cancer. But these cells are smaller and they're darker, and some of them look like lymphocytes here. So what might this be if it's not metastatic carcinoma?
Cutaneous lymphoma?
Yeah, or leukemia or lymphoma. Good. Excellent. And that's what this is. This is cutaneous involvement with leukemia. This is leukemia cutis. Now, why does it kind of look like carcinoma a little bit? What does that tell you about the differentiation of leukemia?
Leukemia cells should be like a disc cohesive, or the carcinoma in theory should be more cohesive looking. And those cells here we see are kind of disc cohesive.
They look slightly, they have more abundant cytoplasm. They kind of almost look, quasi-epithelioid, and they're kind of forming these cords and strands. So what kind of leukemia gives you sort of almost histiocyte-like morphology admixed with some of the darker, more hyperchromatic cells that look more like lymphocytes? And even some that might even be, that almost looks like a neutrophil, like a band form. So what kind of, yeah, AMML. And that's one of the more common forms of leukemia to spread to the skin. So this is AMML. That's what this patient had. So this is good. This education, a lot of different forms. It gives you this interstitial pattern. Leukemia cutis likes to do that. It gives you the Grin Zone. Okay, so it doesn't involve the epidermis. So that's leukemia when it spreads the skin. Now this is a lymphoma. Generally a little different pattern, when lymphoma spreads to the skin. That this may, I think this was somebody that may have had follicle center cell that spread to the skin secondarily. So it doesn't tend to give you that interstitial, mostly pattern like leukemia does. It looks different. Or cannonball type metastasis. And it really actually looks a lot like primary lymphoma also. It's sometimes difficult to tell. So, this is follicle center cell. You could probably recognize right away. Okay, I got one more to do. What kind of biopsy are we looking at here? This might actually affect you guys in the real world. This might happen to you when you're on call.
Is this like a scrape?
Yeah. Yeah. So what are you looking at here? What do we actually have?
Superficial epidermis.
Okay, what's this right here?
Stratum corneum.
Stratum corneum. And then we've got just the very uppermost part of the epidermis, right?
Yeah.
And and these are, what kind of cells are these? They're keratinocytes, obviously. But what's abnormal about them?
Dyskeratotic.
Yeah, there's some that may be dyskeratotic. Yeah, I think that's true. What's the main change of them?
They're discohesive.
Yeah, discohesive or acantholytic. Acantholytic. So when you see something like this, what do you think this looked like in the person?
Look like a bulla.
Yeah, it'd be a blister. High blister, very high in the epidermis. This is like in the, just beneath the granular cell layer, possibly spinous cell layers. This is really high up there. So this isn't suprabasilar. So this would be a very flaccid blister. And when they bring you down to the frozen lab, this rolled up piece of sloughed skin, and they ask you to look at it, what's the differential diagnosis that they're mainly asking you to distinguish? There's two main things.
SJS and TEN.
Good, SJS/TEN. And then what's the other entity? So one,
Pemphigus vulgaris.
I'm sorry?
Pemphigus vulgaris.
Well, not usually for an acute sort of situation. They're bringing out a frozen section. Pemphigus can give you acantholysis like this.
Yeah.
Absolutely. Well, TN is the other one. So TN Stephen Johnson is one.
Yeah.
That's the same thing. EM Stephen Johnson's TN are all in the same family. So that's one entity. The other is the entity that's, you don't have to worry about as much. One, you go home and you watch Netflix. The other one, you're there all night in the ICU. The patient may die. So this is life or death.
Multiforme.
We've already said that. We're talking what is this one here? So you're looking for staph scalded skin syndrome versus erythema multiforme, TEN, Stevens-Johnson, those diseases. Mainly it's TEN. So when you're sloughing your whole skin, you can either slough the skin superficially like this. You got lots of epidermis beneath this. You got plenty of barrier function. You can give this patient antibiotics and go home. But if they have TEN, they're in the ICU. They're in a burn unit. They're worried about sepsis. They're worried about fluid and electrolyte imbalance. They're worried about high output cardiac failure. So you got all sorts of things to worry about if it's Stevens-Johnson toxic epidermal necrolysis. So if they're asking you, you're sitting in the frozen section lab to make this call at midnight, make sure you say, well, this is a superficial blister. It's got acantholysis. This doesn't have a confluent epidermal and necrosis beneath it. So this patient, we don't have to worry about them so much. Okay. Now this one, this isn't a jelly roll technique, but this is erythema multiforme or TEN. Here you've got total 100% necrosis of the epidermis. If they brought you a jelly roll that looks like this, what are you going to tell them?
TEN.
Yeah, you're going to say, don't go home. Get them in the ICU. You know, this is a burn unit situation. I actually was involved in a lawsuit as an expert witness several years ago about a guy in the ER that missed the diagnosis of TEN. He didn't do anything wrong because it was too early, but they were trying to crucify him because the patient went on to do this and they nearly died. So you have to be very concerned if you're looking at the epidermis to be able to distinguish between total confluent epidermal necrosis like this. Everything is dead here, right? There's no acantholysis. Here's where that other blister was, way up here, and there was no death of anything. It was just acantholytic cells. Here we got confluent epidermal necrosis. So this is very important. So for a pathologist, this is, you know, important for you to know this. It's still got a basket weave cornified layer. This happens very, very quickly. It didn't even have a chance to form any parakeratosis. And notice that it's totally necrotic. Everything's dead. It's just like autopsy. So, you know, everything is gone. So we're looking at a confluent epidermal necrosis here. This patient's very seriously ill. The other patient, not so seriously ill. Okay. So make sure you know how to tell this apart, right? You guys think you could do it? So if you're gonna be on call tonight at midnight, somebody brings this in, you're gonna be able to make the diagnosis, right?
Yes.
Okay, good. You better. If you don't, I'm gonna haunt you. All right, that's it, guys. Did you learn
Thank
anything?
you.
Thank you.
Thank you so much. Learn a lot.
Dr. Cockerell.
All right, you guys
Thank
take
you.
care.